In today's episode, we are going over an evidence-based guide to lateral ankle sprains, anatomy, diagnosis, and differential diagnosis. Let's do it. So what's the problem with lateral ankle sprains? So lateral ankle sprains are very, very common. Depending on the study that you look at, it is the number one injury in sports. Okay. Again, that's going to vary based on the population. It's very scary when it occurs. It's one of the major reasons why folks go to the emergency room. Symptoms typically resolve pretty quickly after you have a lateral ankle sprain, and largely that's a good thing. But the problem is that up to 50% of folks after they have a first lateral ankle sprain will have recurrences. So they tend to occur again in the future, or they're left with some sort of long-standing instability, pain, swelling. We'll talk about this a little bit later, but something known as chronic ankle instability, which is another big problem. Largely, it's not taken very seriously as an injury, despite a lot of folks going to the emergency room. A big chunk of folks that do end up with a lateral ankle sprain, they don't end up seeking medical attention. Another huge problem with lateral ankle sprains is misinformation. So let's say you sprain your ankle and you go to Dr. Google, you type in lateral ankle sprain or lateral ankle sprain treatment. You'll have a bunch of information pop up. These were the first three articles that popped up when I Googled lateral ankle sprain treatments. And largely it looks like they're reputable sources. So one is from the Mayo Clinic, one is from UConn, so major university there. The third is just rehabaccess.com. No idea what that source is. But largely, they give information out about using RICE, rest, ice, compression, elevation. And they also largely talk about not ambulating for up to 2 weeks after you have a lateral ankle sprain. That information is just wrong. Okay. So we'll talk about what the evidence says a little bit later about RICE and also about ambulating or walking after you have a lateral ankle sprain. But suffice to say, this information is just wrong. And the sources look reputable. They look pretty good, right? And it's the first few sources that pop up after you go on Google. Now, this is a huge problem because we'll see in a bit, having ankle sprain is a serious issue and it's a big burden on our society from a healthcare cost expense. And largely, if you go on Google and try to find the answer, right, be informed consumer information after you have an injury, you're not going to get good information. It's bad. So that's a big problem. So in today's episode, we have an evidence-based guide to lateral ankle sprains. We're going to be going over the prevalence of these injuries. We're going to go over history and clinical presentation of lateral ankle sprains. We're going to go over prognosis and natural history. So how long do these things tend to get better? What happens to them over the course of time? What are predisposing factors to the injury? What are your risk factors? What is the mechanism of injury? What is the anatomy of a lateral ankle sprain? What is the diagnosis as well as differential diagnosis? What else might be going on at the ankle if you roll it or twist it? What are the best treatments for lateral ankle sprains? How do we return to work or return to sport? And lastly, how do we prevent future injuries? Before we get started, I just want to give you a big thank you for your support. You truly allow me to do what I love for a living. My name is Dan Pope. I'm a physical therapist. I'm a coach, personal trainer, and meathead. This is the Fitness Pain Free Show, where we help coaches and physical therapists like you get your patients out of pain and back to training. If you're watching this on YouTube, hit that like button, comment, and subscribe to the channel. And if you're listening to the podcast version of this, please give me a positive rating and review. Helps me out tremendously. I've also created an evidence-based guide to ankle sprain injuries cheat sheet. It's a handout that goes along with today's lesson. We go over all the basic points I just went over: prevalence, history, prognosis, predisposing factors, mechanisms of injury, anatomy, diagnosis, differential diagnosis, treatments, return to sport and work, and injury prevention. I'll leave a link in the show notes, 100% free. You can go ahead and download that. Again, it's a companion for what we're going to go over today. It's also a really nice reference sheet that you can go back on a little bit later in the future. If you kind of forget what I went over, you want a quick refresher, it's all going to be there. This is part 2 of a 4-part series. If you haven't checked out part 1 first, I'll leave a link in the show notes. Go check that out before you watch this. So the majority of the information we're going over today is from one article. It's from the British Journal of Sports Medicine. I'll leave a link in the show notes so you guys can definitely check that out if you're interested. It's called Diagnosis, Treatment, and Prevention of Ankle Sprains, Update of an Evidence-Based Clinical Guideline. So this was a great paper. It's a little bit older. It's 2018, right? But when I was doing my deep dive, my literature review, and trying to figure out the best papers to include in this presentation today, this was by far the best. So if there's some more information after 2018, I actually included that, and I'll put all of my references in the show notes, but largely the majority of the information today is actually coming from this article. So let's talk a little anatomy of lateral ankle sprains. So lateral ankle sprains make up 85% of all ankle sprains. So there are other types of ankle sprains. We'll talk about this a little bit later, but you can have high ankle sprains. You can also have medial sided ankle sprains. The large majority are going to be lateral ankle sprains. And 65% of all ankle sprains, these are going to be isolated injury to the ATFL ligament. In 15% of all cases, you're going to have a combined injury of the ATFL and the CFL. It's actually pretty uncommon to hurt the CFL by itself, although that certainly can happen. The remaining 15% of all cases of ankle sprains are either going to be a high ankle sprain or a medial or deltoid ligament ankle sprain. If you have a high ankle sprain, that's an injury to the tibiofibular ligaments. And these ligaments are going to connect your tibia with your fibula. And when folks have this type of sprain injury, the pain is felt a little bit higher compared to a lateral ankle sprain where the pain is felt more on the side. Okay. In folks that have a medial ankle sprain or kind of an eversion injury as opposed to an inversion injury for lateral ankle sprains, you may have an injury to the deltoid ligament. One of the reasons why the ATFL might be injured more than other ligaments of the ankle is because it's the weakest ligament. And it makes up 70% of all lateral ankle sprain injuries. The mechanism of injury, and we'll talk about this a little bit more in depth in a minute, is usually some sort of inversion ankle injury. So you invert your ankle while plantar flexed and ends up stretching out or tearing the ATFL. The CFL, or the calcaneal fibular ligament injury, a little less common. This is often injured with an inversion as well, but oftentimes it's dorsiflexion with inversion. If you plantar flex and invert, it's going to potentially tear the ATFL more frequently. If you dorsiflex and invert, potentially you end up putting more stress on the CFL and tearing that. In terms of the posterior talofibular ligament, this is the least common injury of all three lateral ligaments. So what's the mechanism of injury of a lateral ankle sprain? It's largely rolling on the ankle. So if you land on the outside of your foot, let's say that you're cutting in athletics, right? And you land accidentally on the outside of the foot, or you step off a curb and you land on the outside of your foot and the foot inverts. Okay. So basically you're landing on the side of your foot. You can sprain the ankle. And like I said previously, if you land in more plantar flexion, probably going to be an ATFL injury. And if you land in more dorsiflexion, maybe you add in that CFL injury. So again, the common mechanisms of injury are landing from a jump funny, attempting to cut or change direction, landing on the side of the foot, or maybe stepping off a curb and landing on the side of the foot. So we have my ankle here, okay, right here. And you can see this is the side of my lower legs. This would be the fibula. Right here is the calcaneus or the heel. Right next to it is going to be the talus, okay? So the most common ligament to be injured is going to be the ATFL. So anterior talofibular ligament, which attaches right here, okay? So largely if you have someone who has an ATFL injury, this is where it's going to hurt. You can palpate the fibular lateral malleolus and kind of come down anteriorly and inferiorly right next to the talus and palpate there. That's going to be where symptoms are felt in those folks. And someone that has a CFL injury, so we have the fibula right here, and we have the calcaneus right here. Right between the two here would be a CFL injury. And lastly, and this is the least common, is going to be a PTFL, posterior talofibular ligament. So fibula right here, talus right here. This is where that ligament is, right in that area here. A little less common injury, but it's something I'm actually dealing with right now, is a high ankle sprain. So if you look at your tibia right here and your fibula right next to it, the syndesmotic ligament, so the ligaments that connect the fibula with the tibia, are going to lie right in this area and kind of go up between the two bones. And when folks have an injury here, they typically feel pain higher right between these two bones here, okay? So the mechanism of injury is going to be a little bit different for every type of injury, like we said before. So in my classic inversion sprain injury that most folks get, you land in plantar flexion and inversion, okay? And because of that, we stretch the ATFL. In folks that have a CFL injury, that's often dorsiflexion. So here with inversion, dorsiflexion, inversion. Lastly, with high ankle sprains, this is usually going to be a rotation. So dorsiflexion, external rotation injury, which again is going to stretch out this place between the fibula and the tibia, causing injuries here. So, guys, if you like what you're learning about so far, then I want you to go and check out the Fitness Pain Free Mini Course. So, I made a mini course. It's absolutely free. That's the next logical step if you want to learn more from me. So, in the course, we go over 5 lessons. That first lesson is how traditional schooling has failed us, right? So, schooling is phenomenal from a physical therapy perspective, but doesn't really teach you how to work with high level athletes in the fitness world, right? Doesn't always teach you how to do the lifts appropriately. Doesn't teach you about progressions and regressions of common lifts within the gym. Doesn't teach you how to program normally, how to write rehab programs, or how to write injury prevention programs for these folks. Next thing we go over 7 reasons why people get hurt in the gym, 4 simple steps to getting your clients out of pain, how to build the career of your dreams and earn the respect of your community. It's all well and good if you know exactly how to work with folks within the gym. But if you can't get these folks through the door on a regular basis, then you're simply not going to be living the dream that you want to because you can't get the patients through the door that you want to work with. Okay. So I'll show you how to do that. And lastly, we'll talk a little bit about the fitness pain free certification, right? So I'll leave a link in the show notes. I definitely recommend checking this out. Once you sign up for the Fitness Pain Free mini course, you will be automatically placed in the waitlist for the Fitness Pain Free certification. Now, the Fitness Pain Free certification is the course, the certification that I wish I had as a new grad that fills in all the gaps in knowledge that you don't get in physical therapy school. So, A, you'll gain complete confidence working with injuries in the strength and fitness world. You'll learn optimal technique for both health and performance from myself and some of the best coaches in the world. You'll master programming for rehabilitation and injury prevention. Have fun while earning a whole bunch of physical therapy and physical therapy assistant credits. You have 31.5 of those. You'll also gain NSCA credits as well as CrossFit credits if you need those. This is the equivalent of a university education in working with injuries in the weight room. I really believe that. I've been adding to this thing over the past 5 or 6 years. It's massive, a ton of phenomenal information. And lastly, the biggest goal is just to fill your day with the patients you love working with and building the respect and admiration of the communities you love working with. So I'll leave a link in the show notes. Sign up for the Fitness Pain Free mini course. The certification is open 4 times per year for 1 week to enroll into. If you're on the wait list by signing up for the Fitness Pain Free mini course, I'll alert you when that next enrollment period is open and you can get started. Let's get back to the show now. Another important concept to think about is that when you sprain your ankle and roll your ankle, we'll stretch the outside of the ankle. And usually we think about the ATFL being injured, the CFL being injured, maybe the peroneals get a little bit injured. However, you also compress the inside. So when I sprain my ankle, I stretch everything on the outside. I actually compress everything on the inside of the joint. Because of that, you may find folks with bone or cartilage related injuries. Bone bruises are actually relatively common with lateral ankle sprains. Bone can be pretty dang painful. So when you're rehabbing these folks, oftentimes they'll complain of having some sort of medial sided pain that lasts a lot longer than the lateral sided pain. And that may be a little bit confusing, but that could be one of the reasons why. Okay. The other piece to think about is when you have an inversion sprain injury, you could also end up injuring the peroneal nerves. So if I'm going to end range plantar flexion inversion, I may stretch everything on the outside and front of my ankle. And what can happen there is that you have an injury to the nerves. And I had said this previously, but you might end up with delayed reaction time to the peroneals, which could predispose you to more recurrent ankle instability problems because you can't fire those muscles quickly when you land, and you might have recurrent injuries as a result. The other piece I think is relevant is that when folks have a lateral ankle sprain, they end up having a lot of swelling. Again, we'll talk about this a little bit later. They have a lot of swelling. So they have swelling in the front, in the back, in the side, into the toes. They're swelling everywhere. So largely the joint is sitting in this inflammatory soup. So they're probably going to have more pain on the lateral side of the ankle, maybe medially because of a bone bruise or some sort of cartilage injury. But at the end of the day, everything within the ankle is sitting in this inflammatory soup. So they could really have pain all over the place. Okay. So just keep in mind when you're rehabbing these folks, they may tell you they have pain on the front, the side, and inside, on the outside, all over the place. And this is probably just because there's so much swelling irritation. So, what is the diagnosis and clinical presentation of lateral ankle sprains? So, these folks present with a history of rolling an ankle. Oftentimes, it's going to be recurrence, right? We said this before, a large percent of folks will re injure after they have the initial injury. So, oftentimes, you have someone come in, they said, I rolled my ankle, I've done it in the past. Okay. Usually, this is going to be an acute injury. Like I said, people roll the ankle. So if someone had a slow onset of symptoms over the course of time, I'm thinking less of a lateral ankle sprain and maybe something else that's going on. These folks often present with a lot of swelling and bruising, a hematoma, and they may have swelling on the outside of the foot, but it could extend into the toes. And this is probably just because of gravity. So if you have an ankle sprain, it may start with bruising, hematoma, a little bit higher up the ankle, and then it just kind of extends down just due to gravity, right? These folks will often have some difficulty ambulating, especially with those higher grade injuries, so grade 2, grade 3. Just keep in mind if they can't walk for more than 4 steps at the time of the injury, you may want to send them in for some imaging because they may have a fracture. What are some good diagnostic tests for ATFL injuries? So, a good test to determine if your athlete has a rupture is that if they have a hematoma present, if they have pain on palpation around the distal fibula where the ATFL attaches, and or a positive anterior drawer test, there's a good chance they have a rupture of the ATFL. The anterior drawer test by itself has a sensitivity of 84% and a specificity of 96% if the clinical assessment is delayed for between 4 and 5 days after an injury. If you've seen one of these lateral ankle sprains immediately after, I think immediately after is usually not as painful. And then over the next few hours or that evening or the next morning, usually it's very, very painful and very irritated. So if you're doing these clinical tests too early with folks, it might be too irritated or maybe not irritated enough yet to actually get a positive test. So if you wait 4 to 5 days after the injury, they're actually a little bit better. So this test is actually quite specific at 96%. So if you have a positive test, there's a good chance you do end up having a lateral ankle sprain. It's fairly sensitive at 84%. So if you have a negative test, we could probably rule out lateral ankle sprain, although it's not 100% sensitivity. What are some diagnostic tests for the CFL? Well, we don't have the best test for the CFL. Okay. Largely, you can palpate the area. So if there's tenderness to palpation for the CFL, it may help to rule in a CFL injury. We can also use the Taylor tilt test, which has a sensitivity of 67% and a specificity of 75% for a complete double ligament rupture. So largely, the Taylor tilt test is helpful for ruling in or ruling out a tear of both the ATFL and the CFL, but we cannot accurately diagnose isolated CFL lesions well. So if we want to try to get that true answer, we probably have to send in for some imaging, maybe an MRI or ultrasound of sorts. May not have to do that. We'll talk about diagnosis via imaging a little bit later and whether or not we have to go down that pathway. How about grading ankle sprain injuries? So you can have a really bad ankle sprain injury. You're going to have an ankle sprain that wasn't that bad, right? So there's grades. They're between 1 and 3, 1 being the easiest or best type of sprain, not that much damage. And then grade 3 is a worst type of sprain injury. What's important to keep in mind is that all these grades are subjective. Okay, so it's actually really challenging to determine exactly what grade an injury someone has. So just take these grades with a grain of salt. They're not perfect, but they can help determine the severity of the injury. Grade 1 ankle sprains are considered mild. Usually there's some mild swelling, some mild tenderness, and minimal difficulty in range of motion. Grade 2 injuries are a moderate sprain, usually have a little bit of micro ligament lesions associated with this. Grade 3 are the most severe sprain injuries, and usually there is a full ligament lesion. Okay, so fully torn, the ATFL or CFL, and usually there's diffuse swelling, so swelling all over the place, ecchymosis or bruising, a lot of tenderness, positive provocative tests, and oftentimes inability to weight bear. So, what is important from a differential diagnosis for lateral ankle sprains? Well, first and foremost, it's important that you rule out fractures of the ankle. So, this stat is in individuals that ended up undergoing imaging for their lateral ankle, which means they probably had a pretty bad sprain injury. But at least in these folks that underwent imaging, so an x ray for a lateral sprain injury, 15% of those folks actually had a fracture. Okay. So it's important when you have a patient that comes in with a lateral ankle sprain that you try your best to rule out a fracture before starting physical therapy. And if you do have a positive test, we're going to talk about the Ottawa ankle rules, then you send in for some additional imaging. So a really good test to figure out if someone has dealing with a fracture is going to be the Ottawa ankle rules. And largely, if your patient has bony tenderness along the distal 6 centimeters of posterior edge of their fibula or tip of the lateral malleolus, if they have bony tenderness along the distal 6 centimeters of posterior edge or tibia of the medial malleolus, if they have bony tenderness at the base of the fifth met head, if they have bony tenderness at the navicular, or if they have inability to bear weight both immediately after injury or for 4 steps during your initial evaluation, then you probably need to send them in for some imaging. The Ottawa ankle rules are very sensitive. And what that means is that if you have a patient that comes in and all of these tests are negative, there's a really good chance they don't have an ankle fracture. The specificity is not quite as good. So if you have a patient, you palpate, let's say their navicular head, and you find that it is tender, you want to send in for imaging to rule out fracture at this point. Just because it's tender doesn't necessarily mean it is broken. But if you have a broken ankle, the treatment is going to be different than if it's not broken, right? So definitely do the Ottawa ankle rules on your patients before you start exercise. It's important we rule out fracture because we don't want to be exercising on broken bones. We also want to be on the lookout for different types of ankle sprain injuries just because these are treated a little bit differently and maybe they take a little bit more or less time to get better. So one of which is going to be a high ankle sprain. So that's a syndesmotic ligament injury that we just talked about. Typically, these occur with a twisting injury. So sort of dorsiflexion, external rotation of the lower leg can end up spraining those syndesmotic ligaments. Okay. So from a mechanism of injury perspective, folks may say that they twisted their ankle as opposed to rolling it with a lateral ankle sprain. Usually this pain is much higher, hence the name high ankle sprain. So largely these folks will feel pain between the tibia and fibula. It may extend upwards from there. Okay. You can also palpate those syndesmotic ligaments to see if they're irritated, and that may help to rule in the high ankle sprain. You can also try a dorsiflexion external rotation test, which is exactly what it sounds like. Dorsiflex the ankle, externally rotate if that's going to reproduce the patient's familiar symptoms, especially in those syndesmotic ligament location, rules in hopefully the high ankle sprain. You can also try a squeeze test. So you take your hands halfway up the patient's calf, squeeze on the tibia and fibula together, and that will gap the distal tibia and fibula and stretch the syndesmotic ligaments. If that creates pain in your patient, that would be a positive test. Might help to rule in a high ankle sprain. The thing about high ankle sprains, and obviously that's a lesson for another day, is that these tend to take a little bit longer to heal. And the other point is that they tend not to handle rotation well. So early on, after you have a high ankle sprain injury, you probably don't want to do a lot of rotation. But later on in rehab, we certainly need to be able to restore that. So your rehab is going to look a little different from a lateral ankle sprain, which tends not to be able to handle stress in the frontal plane initially. And then later on rehab, we have to make sure we really hammer frontal plane stability to return back to return back to sport and activity safely. We also want to be on the lookout for medial ankle sprains. This would be a deltoid ligament injury. So basically pain on the inside of the ankle where palpating the deltoid ligament hurts may rule in a medial ankle sprain injury. Usually this is an eversion mechanism of injury, so the opposite of the lateral ankle sprain, which is typically inversion. It's much less common. Again, the pain is medial sided. Do keep in mind in folks that have a lateral ankle sprain that roll their ankle, they could have medial sided pain. That could be because of the swelling, or they have some sort of bone or cartilage injury as a result of the lateral ankle sprain. So just make sure you're thinking about that when you're evaluating your patient. And usually they'll have pain with eversion of the ankle. Eversion kind of hurt. Although keep in mind, I currently have a high ankle sprain. I've had some lateral ankle sprain patients in the past. And if you evert my ankle, it hurts me, right? But it hurts in the syndesmotic ligaments. It doesn't hurt on the medial side by the deltoid ligament. So again, make sure that you take all of these together with a grain of salt and use your brain to come up with a good diagnosis. If you guys are enjoying this evidence-based guide, I have another one for you. It is the evidence-based guide to patellofemoral pain syndrome. So I'm going to leave a link in the show notes. I'm also going to leave a link up in the corner. So go ahead and click on that link if you want to continue with the learning. If you guys are interested in the references, and I do recommend you check those out, I will leave them as a link in the show notes and you can get to reading them. Lastly, I just want to say thank you so much for your support. You truly allow me to do what I love for a living. If you're on YouTube, smash that thumbs up button, leave a comment. I love to hear your thoughts on this presentation and consider subscribing. It helps me out a ton. If you are listening to the podcast version of this, please consider leaving a positive rating and review. Helps me out tremendously. And lastly, if you want to go that last extra step in supporting me, please consider subscribing to Fitness Pain Free Insiders. All you have to do is head to fitnesspainfree.com, click on the programs link, click on Fitness Pain Free Insiders online library, just $1 for a week-long trial, and you get more great learning from me. I'll leave a link in the show notes as well, so you can check that out pretty easily. Thank you guys for watching. I'll see you on the next one.